Welcome to The Rewrite. This is the Garage's new quarterly conversational series where we bring together leaders who are rewriting the rules, expectations, and outcomes in healthcare. So we're talking about rewriting the game, rewriting status quo, rewriting what healthcare can become. Each episode will highlight a new theme with new voices, major shifts across the industry. Today's episode features women shaping the future of value-based care. So we're going to start with brief introductions. I'm going to hand it over to our panelists to each introduce themselves. Juliette, do you want to go first?
Sure. Hi, everybody. I'm Juliette Price. I'm Chief Solutions Officer here at HST Global. We're a niche consulting firm that focuses specifically on the move to value-based care here in the U.S. and actually all around the world. We work specifically with payers, providers, health systems, entire nations sometimes, anybody who's really looking to move away from fee-for-service and get into value-based healthcare. We've been at this for about 8 years now. And we're just having a great time as we go along. Thanks for having me.
Very nice. Andrea, you want to introduce yourself and tell us a little bit about yourself?
Yeah, thanks for having me today. I'm Andrea Osborne. I'm the Chief Operating Officer for Belay Health Solutions. Belay is an MSO, and we operate 2 MSSP ACOs as well as an ACO REACH, and then have multiple commercial and MA contracts. We work with health systems and independent providers to offer them a value-based platform so that they can get into value-based care, and then we support them throughout that tenure with us. Additionally, I was previously with another value-based company. I've operated about 14 ACOs at this point in time. Have the opportunity to be a NACO's board member, and then I also co-lead the ACO REACH coalition with APG. And then prior to value-based care world, how I actually got in here was I was a nursing home operator for 16 years. Still have my license, but unfortunately don't work in that realm anymore. But spent 16 years in the nursing home industry. So I truly love working with the elderly.
Very nice. Very nice. So you guys probably know us. My name's Jessica Robinson. I'm the Chief Platform Officer with The Garage. And I'm Stacy Fox. I'm SVP of Market Development and Growth with The Garage. So for kind of the first segment, we really want to understand kind of who you are, what was your story. So none of us essentially landed in value-based care on accident. What was your path? How did you find VBC? How did it find you? And kind of where did you get your start?
I'm happy to go. So as I mentioned, I was a nursing home administrator, and I worked for a company in the state of Indiana. We had 78 nursing homes, but we had one of the first pioneer ACOs in our area with the health system. And so they were trying to figure out how were they going to build their preferred provider network. And so I started meeting with them, talking about what the nursing homes could do, how we could assist the hospitals. And I punished myself by reading a majority of the Affordable Care Act when it came out so that I would understand it. But taking the time to read that, and I was one of the first people to know what the possibilities are. And so I started working with the hospital saying, I will help you build your nursing home portfolio and how you work with nursing homes and how you measure it. I'm just going to ask that you include the nursing homes I represent. And so I did that with one of the pioneer ACOs. And then as MSSP became bigger and bigger, I went to all the hospitals and said, I'll be a free consultant on behalf of the nursing homes. You just have to put my nursing homes in. And so through that, ended up actually then moving to a health system and operating their ACO. But what I loved about this and what I tell people is, I don't touch patients anymore as much as I miss working directly with patients. But what being in value-based care allows us to do is to help form the Medicare rules that will affect all of us as we age. We get to operate on a bigger platform as we operate in these models that are testing grounds to help form what does that test look like, and to be there to be representatives for our patients and for our providers to ensure that what moves forward as regulation we know works and is in the best interest of both providers and patients. So I hope that the work that we do has a larger impact for the future of Medicare.
Very nice. Juliette?
I love that. I also love that Andrea and I come at this from different perspectives and point of view and paths to get here. So prior to starting a consulting firm, I had been a lifelong public servant. worked for the state of New York for a very long time, working to improve public systems. And it didn't just limit themselves to healthcare. I've also worked in higher education and then the K-12 system as well. And so it was interesting to find myself in healthcare. And I think sometimes I talk about this as like, it's really about this is it's really about this delivery system, improvements that can be made. And those are needed not just in healthcare, but actually in lots of different public systems. And so I ended up finding my way to the New York State Medicaid program, where we were under an 1115 waiver, which many people probably know a lot about, which gives you the opportunity to totally rewrite the rules, as Andrea was just saying, right? And for many states, Medicaid is the number one budget item in every single state budget. In New York State, it's a $10 billion program. So every single year, it's a huge responsibility. And we were really working hard to figure out how can we get better outcomes. And through the 1115 waiver, we had a provision of that waiver that said that in 5 years, we needed to move 80% of the Medicaid spend into value-based contracts. Now, we were starting at a baseline of like 0, maybe even -10. Sometimes I think about it now, looking back. And so this was a huge opportunity for New York State and the Medicaid program. And as Andrea so rightfully reminds us, the patients, right? The folks who are on the Medicaid program, which obviously Medicaid covers the elderly, the disabled, 1 in 4 children in this country are on the Medicaid program, right? It's a huge number of individuals who need us to deliver really, really good outcomes. And so it was through that journey that obviously we had to figure out how we were going to lead all of New York State Medicaid, which, by the way, most of the providers in New York State do accept Medicaid. And so this was really an opportunity. I love how Andrea just framed it. It was really an opportunity, yes, to impact the Medicaid program and those patients, but really the entire delivery system. And so over 5 years, we did end up moving 80% plus 86% of the Medicaid spend into value-based contracts. Those look really different for different types of providers, different entities, different players in the ecosystem. But one of, I would say, my proudest moments was leading one of the very first VBC pilots, which was what we called them back in the day. And really getting in there with both the payers and the providers and figuring out, how is this actually going to work? Fast forward all these days, years later, days and years, New York State still remains one of the leaders in value-based care for the Medicaid population. And now we have expanded and we work not just with Medicaid providers, but also Medicare providers and some commercial providers. But it was really through Medicaid that I got my start with value-based care.
I think what Juliette said is so important. I love that you were on the Medicaid side helping the state, because I think one thing value-based care has done is it's allowed the delivery system and those who are writing the regulations to work more closely together. I feel like I have seen more partnership in the last 10 years and each side providing feedback and each side understanding that one, as a provider, when I look at those who write federal and state regulations, we're asking a lot of them. We're asking them to write something that fits everybody, and everybody looks really different. And we're asking them to do that in so many areas, not just healthcare. We're asking them to be experts on so many things. And then as a provider, we're trying to adapt. And I feel like value-based care has allowed us to really start talking so much more. And that makes me believe that we will get there.
I love that. A wonderful segue into the next topic, which is there's a lot changing in value-based care right now. There's CMS programs. There's One Big Beautiful Bill. There's reimbursements, accountability. What would be some of the current policies or CMS moves that are creating the biggest impact for you guys?
I'll start with a meta trend, and then I think Andrea and I can probably go back and forth. But I would say at the absolute 100,000 foot view, it's the unsustainability of health systems today. And that I mean in the broadest sense possible. So I do a lot of work outside of the United States. Every single country on the planet is struggling with this, right? At its core, we have fundamentally structured health systems, not just healthcare systems, but just the globality of how we attack health for our populations, typically based on outdated tax policy and outdated demographics. And suddenly every single country is finding themselves, some exceptions, is finding themselves with a shrinking younger population, less high unemployment, inability to fund the aging population, which, by the way, obviously we are at the crescendo of what 20 years ago we used to call the silver tsunami, and somehow people are surprised that it's here, right? Like, we knew all of this was going to happen, and yet it's happening, and now we're like, I can't believe it's happening. So I would say, like, really to start at that level, that's the challenge, right? Fee for service as a delivery system is fundamentally not going to make it. The sustainability, the raw dollars and cents cannot happen. Nobody has the budget. We've worked with even, Saudi Arabia, countries who have, incredible sovereign wealth funds. They can't afford it either, right? And so part of this has to, I think, start with that honest conversation. This is about the sustainability of the health systems that we all have to live and be patients in, as Andrea so rightfully reminds us, right? We also are patients in these systems. So I think I would start the conversation there. Obviously, there's a secondary piece to that, which is when you look at countries, I'd say specifically in the United States, when you look at the outcomes that we're getting for the amount of money that we're spending, I don't think there's a single person, single policymaker in the US who would say, yeah, I feel comfortable with that, right? Like, we are spending so much and we're not really getting much for our dollar, if you want to think about it that way. Other countries have different, efficiency ratios, but ultimately that's the 100,000 foot. Maybe I'll pass it to Andrea to bring this down to the 50,000 foot for a second.
That was well said. And is it wrong that it makes me feel a little bit better that it's not just a USA issue? Because I so focused on the USA, and we always hear we spend the most money, yet we have some of the worst outcomes for a first world country, which is so disappointing. I think there's a lot of changes happening right now, and my hope is that we find a path forward before, some of the Medicare Trust Fund runs out. And that, to me, that is a really scary thing. I think the other thing with healthcare, and we see this right now as we've had a change in administration, is whether you're Republican or Democrat, the goal is the same, right? The goal is a healthier country that has great outcomes where patients can get the care they need at the right time. And that's what needs to stay the focus. I don't care what you call it. I don't care whose name is on it or who identifies with it. And it's not a bipartisan issue. It's a nonpartisan issue. It's about patients. And that has been one of the biggest struggles, wondering every 4 years what will change, because we're all trying to build around a model of sustainability, and we don't know what change will happen every 4 years. I think the other focus is we as a country often get really focused on hospitals and what's happening with hospitals, but really hospitals are the exception. Hospitals are when something has failed for a patient. Where a majority of care takes place is in primary care and then in the specialist offices. And really want to make sure that what we're looking at is how do we drive healthcare, not sick care. How do we drive healthcare to keep patients healthier? And are the laws and regulations we're creating there to drive patients to be as healthy as possible, as long as possible?
Yeah, it's interesting. What you both were bringing up really is, I've always looked at, value-based care is more putting the health and the wellness in the care and a little less focus on the sick care. We need the sick care because things happen. But the wellness and that preventative kind of push is really lost, I feel, in, health once we kind of become an adolescent. There's not those annual checkups, making sure we're meeting those marks. And then it's kind of like, all right, figure it out. You're an adult, you're out in the world. The laws and the legislation and the framework of what we have in value-based care is really just good medicine. This is what doctors went to school for. This is what they were taught to do and how they were taught to kind of take care of their patients in the right way. So from that perspective, it's all the right thing. We want everyone to be healthy. And then there seems to be a little bit of, more of operational and technology challenge of ensuring that we are getting where we need to go from step A to step B. So physicians are graduating, becoming physicians. They're going through their residency. They're out in the world. They know what they need to be doing. But how are we not able to, or what do you see as kind of why we're not able to show that these physicians are doing what they need to be doing and kind of proving the value-based initiative is really going where it needs to go and doing the right thing?
So I think one of the nice things, or one of the positive things I've heard from the current administration, is their support for improving technologies and the ability for technology to touch each other, to interact and engage with each other for both physicians, providers, and for patients to have access to their data. And so knowing that is, one of the things that they're really working on makes me positive, makes me hopeful for the future. But I think one of the issues with technology, there is a lot of it, but we don't have a lot of requirements for how it interacts with each other, that it's accessible. And so often I see technology built and it's not built with the patient in mind or the provider in mind, which again also makes it not as usable. So it's not about having more technology. To me, it's about having the right technology that can engage with each other and keeps the provider and the patient at the center so they can access the information that they need.
Yeah. I mean, I think so much of this gets back to sort of what we were talking about earlier, right? If the health system, right, we often quote, I think it's Peter Drucker who said this, the systems thinker, right? Systems are designed to get the outcomes that they get, right? And so it is no surprise that the electronic medical record was created to increase fee-for-service billings. And that is exactly what it did, right? And so we can't be surprised that, to Andrea's point, it is not physician-friendly, certainly isn't patient-friendly, certainly isn't value-friendly, right? Because that was built for the old fee-for-service system, right? And so as we move over into a value-based care system, yeah, there's going to be a lot of challenges, and interoperability is certainly top of the table. Access to data, timeliness to data is a huge issue. There is nothing even the best value-based care doctor in the world can do with information 6 months later that someone was admitted or discharged to a hospital. There's nothing that person can do, right? It needs to be real time, as close to real time as possible. I agree with Andrea. This administration has, I think, done a lot to put that item on the table. And we're also, I think we have to be realistic. It's not going to get solved in 4 seconds flat. But at least an administration that is pushing and is being vocal about that needs to happen in, not 4 seconds, but also not 40 years is very helpful to folks who have been in this field. But I also just want to mention something else, which maybe again, bringing us back up a level. It matters what the outcomes are. Because for too often in this country, our outcome measures are not true outcome measures. I'm sorry, but a breast cancer screening is a process measure, not an outcome measure. And I think it is high time for us to have that conversation. And again, I applaud this administration for cracking that door a little bit open. If you read CMMI strategic plan that was released earlier this year, they talk a little bit about that. Is maybe we need to take a second look at measures. This is where I would urge folks to look at what's happening in Europe. Europe absolutely is ahead of us on patient-reported outcome measures, standardized set of outcome measures that are usually grouped by disease state or patient group, I would say, that actually measures true outcome. And where Europe is, I would say, ahead of the United States is that they're actually measuring themselves against outcome measures. And that's enabling the ecosystem of providers and clinics and hospitals to do real improvement work. Now, where I do think we're facing this pressure already is in some of the CMMI programs, where some of the, let's just be pleasant and call it, some of the gaming around either benchmarks or risk scores, as some of that starts to get stripped out of these programs, you're going to have to do a lot more to hit those budgets, right? You're going to actually have to change how healthcare is provided. And that's where I have the most amount of optimism, where value-based care is going to get really real, really fast. Because unfortunately, there's been a lot of folks who have been in some of these programs and haven't yet gotten to that care transformation piece of value-based care. And I think as I sort of talked about it as like the floor is rising. The bar is being set a much, much higher. You're going to see some of that. And I think the key piece that we can't miss here is we need to really look at those outcome measures and really understand what it is that we're measuring.
I completely agree. It's one of the reasons I like the ACO REACH model, because it was outcome measures. It wasn't process measures. It was outcome measures. And I think that makes a difference.
Yeah, I see a huge need for that because value and health and wellness is kind of that goal, right? So looking at, what the gaps are and where we know we need to go. I want to take a minute and just kind of change of focus a little bit more on what is the leadership? What are the strategies that are amplifying, your voices to kind of drive change? So when we talk about, kind of the voices of impact and women leading change, where do you find, in your own kind of spheres within your ecosystem and in your impact roles within your organization and within NACOs, et cetera, what is it that you see as far as leading change, in an approach, in a mindset, in a practice that's kind of helped you to allow others to see the impact or to influence them on kind of seeing that other side of the conversation, from your perspectives?
Well, we got into healthcare because we wanted to take care of people. We wanted them to do better. And at the end of the day, that's where we get our fulfillment from, is taking care of them. And we get to see that in value-based care. And I think when we were just doing fee for service, we weren't always looking at the data in the same way. We were looking at data of how many days is someone in a bed? How many surgeries have we done? How many x-rays have we done? Have we used our MRI machine? But when you look at value-based care, you're measuring those outcomes and you're measuring the impact it has on patients. And so now the data we bring forward says, hey, this patient has been to the hospital 15 times in the last 20 weeks. That patient's not doing well. Let's do something different. And often what's different sits outside a normal just E&M visit, right? There's typically something else happening. And in value-based care, we provide the team. The payment is no longer about just the visit. It's no longer about how many patients can I see in a day. It's about keeping patients healthy. And so I think so much of it is being able to share the data and being able to show the incomes. You make money a different way, but you make money from keeping people healthy, from keeping them, from preventable uses of hospitals and surgeries and post-acute care. And that makes a difference. So being able to show patient level data and where there's that opportunity is just so critical. And that's the care providers really want to give. And it's interesting, when you're meeting with a practice who wants to move into value-based care and you explain what it is, they say, that's what I've been wanting to do. That's what I try to do. I just don't get paid for it. And they just say, yeah, value-based care allows you to get paid for all the after hours calls that you've been taking, because our reimbursement style is different. It's not about how many E&Ms did you do in a day. And to me, being able to show a different viewpoint that's focused on patient outcomes and the way that the physicians find more satisfaction in their day. And I think that both improving the physician satisfaction with their day and their hours that they work outside of on call and in the office is really what helps to drive. And that willingness to say, let's look at it a different way. I don't care how you've done it the last 10 years. We can do things differently. That's okay. And that's what value-based care allows us to do, is to look at things differently and operate differently. And so often it's the way a practice actually wants to operate.
And I would love happy doctors. Nobody wants a grumpy, stressed out doctor, right? I was going to say, Andrea, there's so much physician burnout. We'd love for you to give us an example of, maybe a shift that you guys did where you really impacted their burnout or, their willingness to do something differently. Like you said, they get everyone gets stuck in their ways. We've been doing things for 10 years and this is all about rewrite. So how did you give us an example of something that you guys kind of rewrote, whether it was technology based or just a shift or a workflow that you really saw an impact?
So I think looking back through my history of working with providers, especially when they were providers employed by the company I was with, it was being able to take providers and saying, you no longer need to see 40 patients a day. Instead, we want you to see 16 to 18 patients a day. In your annual wellness visits, you get 45 minutes. Your transitional care visits are going to be 30 minutes. And changing that timeline so they felt like they were fulfilled and able to follow up with everything while they were in the realm, it was provided so much satisfaction for our providers. And it wasn't a pay cut because we changed the way that they were reimbursed and matched value-based care. So they were no longer on an RVU only model. I think the other thing that's happened is when we bring in technology, one, we always make sure the technology company has had, whoever's the end user has been providing input as it's been developed. So I'm always going to ask, what physician worked with you on developing this? And have they used it in their workflow? Because that physician feedback is important. And when we're working with providers, we always say, tell me how the technology helps you. And because if it's not helpful, we're not going to use it. If it doesn't make your life easier, then it's not doing what it should do. And so really making sure that technology supports the physicians. We're not asking the physicians to support the technology.
I think that's really important. Juliette, anything on kind of your side from that perspective? How have you kind of influenced your team or even some of your clients that you're doing consulting with across your organization to just kind of look at it differently? How did you kind of change their focus or their perspective?
Yeah, I mean, I think there's a lot of role. There's huge amount of role for women in this move to value-based care, right? I'd say primarily you also have to think about this is the area, primary care is the area that is most dominated by women. We're still not the majority. It's about 40% of primary care providers are women. But that and pediatrics are the two areas where you actually see more of majority of the workforce. And I'm generalizing here and just, thinking about MD, right? Nurses and other members of the clinical team, you see different, you see different ratios. But so first of all, I would say, and I say this all the time when I talk about value-based care. Value-based care is highly technical, yes, but at its core, it's a huge power shift. And Andrea sort of highlighted this, right? It's moving away from hospitals as the center of our healthcare system to more primary care. So already that's a huge power shift that is happening, whether or not primary care physicians are aware of this. More often than not, I find that they're sort of new to this realization of just how much the power is shifting away. So I think that in and of itself is naturally a place, right, where women have a seat at the table. There's so many great women pioneers. I think of Kelly Conroy, who was one of the very first, ran Palm Beach ACO, right, from the get-go, right? Now we all know Palm Beach ACO is this national model held up, but, Kelly was really one of the originals. A lot of FQHCs, federally qualified health centers, are also women-led and women-run, right? I think this goes back to Andrea's point of why folks get into this business. Running an FQHC is not for the faint of heart. You're taking care of sometimes some of the most, sickest, most, needy communities, and those are often led by women. I would shout out, Brittany Silvestri, who runs Hudson Headwaters Network in the northern parts of New York, one of the largest FQHCs, right? You folks internationally too, I think of Sally Lewis, who brought value-based care to Wales, which is obviously part of the UK. You have Jennifer Bright, who runs ICHOM, the International Consortium of Health Outcome Measures. I mean, everywhere you look, I think we have amazing women leaders. I would say for me, there's a lens here, which is that, fee for service, it's exactly that. It's exactly what it sounds like. Fee for service. It's sort of a business transaction. I think when you move to VBC, and you sort of alluded to this, Jessica, it's more, you have to think more critically. You have to look at the whole system, right? Andrea was talking about if you're a hospital, you suddenly have to know what's happening in your nursing home across the street. That's a much more systems thinking orientation, which I find women to have a little bit more of a natural sort of like predisposition to doing that, right? Women have a better sense of connectivity and relationship and the value of those things. And I think that is where we see some just tremendous women out there who forget VBC a little bit faster, more instinctively. And I also think to your question, Jessica, about, how do you change people's minds? I think, healthcare for a very long time, including today, it's a male dominated field. And so women are used to having hard conversations and having to make room for themselves at a lot of these tables and decision points. And so I think when it comes to convincing a clinical team, there's no one better to do that than a woman, right? Because they have had to have those tough conversations before. And so I think that's really where you see women excel in this field.
And I think where we go from here, Juliette, like if you were to give advice to women trying to come in and have some of those tough conversations, what would that advice be?
I think, first of all, it's leading from a place of honesty. One of the things I just instinctively love about value-based care is it's no longer the person with the biggest stick in the room, right? The FDR quote, right? It's the person who actually has the truth, right? It's the person with the data. It's the person with the total cost of care. suddenly all of these other things that have always been present in conversations sort of die down. And so I think when you lead conversations with data, with facts, those always, and I'm sure Andrea can attest to this, right? Running ECOs is nothing if not showing people their own data and having really tough conversations, but backing up, usually realities that maybe people don't want to admit, with really good coaching, right? Everybody, once they know that they're not doing the best that they can, they want to know how to get better. And so I think it's a lot of that, bringing the right information to people and then following up with really, compassionate and empathetic coaching. Everybody wants to be better at their job.
I don't think any physician or anybody in healthcare has ever wanted to get in that role to not do well by their patient or not do the right thing and have a healthy group of patients. So that's exactly it. We want to make sure that everybody's healthy. So we all want to do better. But Andrea, as you know, working with physicians and showing them their data, that's not always what it's showing. That's not always the truth when the numbers are all coming out the other side.
That's really true. And we see that, I personally have seen that a lot this year as MSSP quality reporting changes. And now that it's all based on what's in your EMR, simply putting the right data in the wrong spot can make you look like an underperforming physician. And so this is again where technology can either help you or hurt you. But we got to make sure that our providers know exactly where to document, or else they look like they're underperforming, and they're not, because they're not able to show the data in the way that the EMR or technology is able to pull it in. So I think that is important, and that's why data is critical. The other place, and I'm going to go back to a few things Juliette said, is when I talk to women who are entering the workforce or newer in their career, I tell them they need to keep their own data on themselves. You need to know your value and you need to document it. So when you have a good outcome, when you achieve something, I always say, take time, just keep a note on your computer where you document when something went really well. An email was sent by one of your practice to the CEO commenting on how great you're doing. Make sure you keep a copy of that. You achieved an outcome. Make sure you keep a note of that. That way, when you go and have a conversation about wanting to apply for a new job, getting a promotion, changing your salary, or if it's just the end year review, you have notes on all the things that you've achieved that year. Because so often we wait till we go into our end of year review and we're trying to remember what we've done. Yeah. So I always tell them, take the time to keep it on your computer when something goes well. Keep the data of your own success. That way you know your value and you have that to support the request that you're making.
Yeah. It's great advice. Yeah. Okay. For both of you, if you could rewrite just one thing in healthcare or value-based care over the next 5 years, what would it be?
It's a big question.
I know.
We
could hit anything. It could be a shift. It could be an action. It could be technology. It could be, a new policy. It could be the 1115 waiver.
I would do two. One, that there would be a central technology that all EMRs would be required to download to on a nightly basis. That way, a physician can go into one central place and see everything in the country. And if your EMR can't do that, then it's not one that gets used anymore. So that we truly have interoperability and everyone able to see everything else. I think if there was another one, it would be that this one is a hard one, but it'd be that we would solve how we reimburse physicians and that we would move the money to preventative healthcare, and really that primary care would be one of our highest paid specialties. Over other settings, and that they would be there to drive keeping people healthy, and that would help move more upcoming physicians into primary care, but also allow them more time to spend with patients, which happens in value care, but does not happen under fee for service. And so really making primary care the quarterback of care and showing that financially.
I think if I had to change only one thing, which is a tough question to answer, I would change the outcome measures that we're working under. I really am a big believer in continuous quality improvement, and what you measure gets managed. And I really think it's time for us to let go. And I know some of us we're afraid and we're not sure what it would give, but I just think really moving away from process-based measures to outcome measures. We did it under the New York 1115 waiver, right? Our outcome was avoidable hospital use, and we had a mandate to bring it down by 25%. everyone told us in 5 years was impossible and crazy. And we beat our goal. And it's only because there was a single clear measure that was not arguable, was a true outcome measure. And everybody attacked it a little bit differently, right? Which is the beauty of different communities and their approaches to health and healthcare. But I would really say, I think that would be the one thing that could really move the system. And I know the measurement industrial complex, as I say this, is getting to work on, 1,000 reasons why that can't be, but it can be. And I think hand in hand with what Andrea said, with interoperability could make a real difference.
Very nice. I think that I would say I'm impressed with all of the responses to that last question, because I think that my brain's kind of thinking of what are the things that we can do to kind of get other outcome-based measures, just because it's not something I get reimbursed on, but how can I put something that's, in the forefront for physicians to really see, like, what is it that we're doing here? What is that? Population health has a lot of different answers to the question or the definition. But, at the end of the day, how am I moving a population from not well or well to the wellest they can be, improving that quality of life, getting them to, the best state that they can be. And that's really the outcomes that we want for all of our patients.
This is the second year that we run WAVE, Women Advancing Value-Based Care and Equity. It's just it's totally free for anybody who wants to join. You just have to be a woman working in value-based care. We do monthly chats. We usually have someone present on their work. And then, it's just a great community, to get to know other women in the space. We also lean on each other for advice and tips and things like that. So, happy to share that link. And there's a great LinkedIn group, if women want to continue the conversation and get to know each other more.
That's great. Thank you so much for both of you joining us. I'm really excited to, see some of the feedback, that we get on this. Before we go, I just want to say thank you very much, Andrea and Juliette. We heard a lot about the importance of value-based care. We heard a lot about how we are not the only ones struggling in the entire world, which is, I think, comforting, but also shows that there's a really big problem that we need to bring into the table and really look at it from a system perspective and understand how can we see what's working well in other countries and other organizations that are doing well in certain areas and bring that into, our wheelhouse for our positions and our organizations. And then really understanding that there is a voice for all of us in this world. We have a system that's working, but it's not working to the best of its ability as we do this transition. So we need to make sure that, we're all keeping the right frame in mind when we have these conversations and not being afraid to kind of call it out when it's not doing the right thing for us. And data is going to be key, regardless of whether it's your own data, Andrea, which I thought was really an important piece to bring out. Not only was it your own data personally, but the data across your physicians, your organizations, and looking at where is that data taking you and is it going in the right direction? What we have a metric on is what we measure. So I think that's really, really important. For our second episode, we are going to focus on rural health transformation. So that's going to be a big shift in healthcare and kind of the spotlight. So that's going to be next quarter. And I hope that you all join us again for future conversations.